I'm Dr. Chao. I think someone is have seen me maybe 2 days ago. I think for you, maybe it's just a noon time or afternoon time. As because of this kind of very severe condition, I hope we can transfer some useful information to all of our colleagues. So today is my topic is ultrasound imaging features and criteria for clinical severity and COVID-19 and NCP cases. So let's start it. I think you're all familiar with this map. It's because of this from WHO official website. You see, you know, it's more than 100,000 cases now is confirmed as COVID-19 disease. So I think now we can call it the pandemic. So it's a very, very severe condition. So in this condition, we hope we can give you some little bit of help. Even we just try to tell the best. Okay, as you can see now, I think it's January 28th in 2020 is WHO published this kind of guidelines or guidance for all of our doctors, nurses to control this kind of a disease or this condition. So they just stratified this kind of disease to maybe some mild or moderate or severe or some sepsis or even septic shock or ARDS in different level. But all this kind of information now is, I think, is last more than 1 month ago. So I think something we have to update. So you can see here is from China. It's the Chinese government published this kind of guidance. It's also now is updated to seventh version. So I think the first part is not very important. So I just follow my picture to go on to tell my story for this information. So okay. So in this seventh version is lots of changes, but I think the most important part is as per just involved some very useful information from some pathology part. You see here, this is from I think it's the first very useful information. It's published in I think it's a preponed kind of a journal. So this is I see yes, it's a 48 years old old female patient and no respiratory syndrome such as fever during onset. The patient's cause of lung cancer just did this kind of operation, and day after the operation, they asked the patients did the CT scan and showed change after you see the lower part here is kind of a very useful things. And also this, I think most of our doctors, if you want to take care of your patients, help your patients, your thinking is from the very basic part, is from the pathology part. You see this is the first, and then this kind of change or just combine some kind of image, for example, CT scan or X-ray or chest X-ray and even our lung ultrasound. And if you use this kind of information and you put it together, then you can thinking about pathophysiology part, and you use the other information together like cardiac output, hemodynamic information, or from monitor from your maybe prescription or interventions from your team, your nurses, your RT or other person, and use this kind of information together and give some right decision and give the patients interventions like this picture from Dr. Zhu Ran. And you see is they integrate this kind of all the information and become a clinical manifestations and management. And let's back to the pathology part. You see here is this cases reports from the very early stage biopsy. This patient is, I mentioned before, is 48 years old female. She did operation, and after that, the day after of this operation, she did a CT scan and showed something here. Let's say this here. You see the CT scan showed the image on post-operative day 1, showing post-surgery change in right lung and increased the ground glass opacity bilaterally. You see the two arrows showed this part. And in this condition, you also can see they use this tissue to do some biopsy and some kind of information to give us. You see it's kind of exudates in alveolar space and lots of granulars and intra-alveolar fibrin with early oxidation and mononuclear and also inflammatory cells and the other cells and hyperplastic pneumocytes and some with suspected variant inclusions. So in the first part, we see this pathology give us some kind of impression is or ideas is the damage most in the epicellular cells and not for some endocellular part or cells. So after this, in China, they still have the other things is from the other cases is 68 years old patients in the study just returned from Wuhan to Shenzhen in January 4th, 2020 with a symptom of high fever and cough. The patients don't have, the patients have 8 years history of hypertension and know the other underlying disease, and the cardiac function is very good. And during this condition, the patients back to Shenzhen after that have very high temperature and developed severe ARDS. So the doctors decide to transplant the lung of the patients. So they cut down the lung and did this biopsy here. And you can see lots of things is different. You see in the different part, the atrophy and the shading of the alveolar epithelium is, I think, in this part. This and type 2 pulmonary cell hyperplasia, and also protein-like exudation with granular scattered protein-like globular bodies and fibrin molecular and multinuclear granule cells in alveolar. So in this area, we still can see these patients, the damage is located in epithelial side and also some interstitial part. But now we don't have a lot of information to see is damage to the vasculars. So the endothelium now in this stage seemingly are likely to see is still okay. And these patients, after several died, they just cut down the lung to see, you see it's diffused congestion and some hemorrhage and necrosis. A lot of things happened with the lung, and the whole lung surface of the cases is frozen, and diffuse congestion was visible, and also most part we can see the hemorrhage and some necrosis. It's notably is hemorrhage necrosis mainly occurred in the outer margin of the right lobar lobe, middle lobe, and upper lobe of the lung. And the bronchus is covered with mucus and bleeding exudates. There was several congestions and this hemorrhage changes in the lung section. So you see this part like this. And if we go deeply, we see the lung, we can separate it into different parts. Some part is a bleeding area, and the other is no bleeding area. And we see it's diffuse intra-alveolar hemorrhage, partial alveolar wall rupture, alveolar fusion, large number of red cells, and type 2 alveolar epithelial cells, and macrophage and histiocytes mixed together and form a cell ambulars and to filling alveolar cavity. So I think this is just along the time in the progressive stage of this kind of disease, you can see something changed in the lung. Now it's come into interstitial part, not only is epithelial, and now it's damaged the alveolar. And also in the area of very severe hemorrhage, alveolar walls distinguish and coagulative necrosis occurs, and the cell plaques in the alveolar cavity dissolved and liquidify, forming mucous substance which is mixed and something like it's a cellular or no, it's protein-like plaques, something like that. So I think during this part, we now is the patient's condition now is just worse than before. And this is published in Lancet Respiratory Journal. Is published by Professor Wang Yongfu. And this patient is died, but you see the left side, the image shows that right pleural thickening and extensive adhesion with the right lung. So you see the damage also, this kind of disease also damages the pleural. And gray-white patty lesion and lesion in the left lung, and gray-white vessels fluid overflow in the lung section, and fever band can be seen. And I think you all know this kind of word. I don't need to read for you. So you see this kind of things is happened with the lung during the, I think it's the end stage of this disease. So the lung was damaged very severe. So if you see the CT scan or you combine this kind of information to the image, like CT scan, X-ray, or even our lung ultrasound, you can think about this part give you what kind of ideas. So you will think about maybe the first part, you just think B line or even A line. And in the end stage, you maybe think about some consolidations, pleural effusions, something like that. And I think the right side is pathological manifestations in the right A or B, just the lung tissue, liver tissue, and heart tissue, and show us some kind of this kind of barriers can even damage the other organs. So from this kind of pathology information, we know this kind of a virus must damage our lung, especially the first stage is amphicellular part, or our alveolar part is first. So if use this kind of information, just combine our CT scan or X-ray, you will see in the early stage, we see multiple small patches, shadow, and interstitial changes, especially in the lung peripherally. So you see this part is from the peripherally, the laterally, and in this area, and not gravity dependent. And in the progressive stage, multiple ground glass shadow and infiltration shadow in both lung you can see here. And in this stage, you also can say it's not gravity dependent. But in very severe condition, you will see lung consolidation may occur. And in this stage, you will see the consolidation most located in the lower part of the lung. I think now it's become gravity dependent. And in this kind of pneumonia or disease, you sometimes you can see the pleural effusion, but not very much. So from this part, now let's think about some X-ray or from our CT scan. So you see the NCP, that means novel, we can call it just COVID-19 pneumonia. So this kind of distribution characteristics mostly distribute into lateral lung field and subpleural. And also, you should think about the central lobular area and alveoli. So this is causes this kind of dynamic. It's a very small variance, so it's very easy to when you take a deep breath, it's just going to your deep alveolar to the peripheral part alveolar to your lung. So let's see cases is from different days. You see is January 31st, and to February 22nd. So this is two CT scans shows the different, little bit different cause of the case, the cause of the disease variation. So you see, in the first part is kind of infiltration or defiltration part in the how to say the laterally part of the lung, and after several days, I think mostly is close to 20 days after that, the patient's the lungs absorption and become more fibrosis. You see here's the most part become fibrosis. And the patient's condition at that time is much better than before. So the patient's the lung X-ray or lung CT scan showed us, I think it's the same as pathology, the basis. And if the patient's in the end stage or in the very late stage, you will see the lung more become a consolidation or become very small or very stiff. And in this condition, you can see CT scan, we call it air bronchogram. So in this consolidation part, you will see the airways here and low. I don't know how to call it the English word, but you see here that the airway is now is very clear. And after this, I think this is a very basic series. And now let's go into our all interested part is ultrasound. The Chinese critical care ultrasound study group has also published this guidance, or our we call it group ideas. to all of our colleagues. You see here is recommendations for treatment of critical ill COVID-19 patients based on critical care ultrasound. So in this guidance, you will see we also need to understand some very basic part of the mechanisms. You see here is the lung ultrasound, the image, the mechanisms, and the science. So mostly the lung ultrasound, the image is based on the air and the tissue, the ratio between these two matters. If there is only air, you will see the A line, but no lung sliding, like the first part. And we also call this part is pneumothorax. So A line, no lung sliding. And if the ratio little bit lower than 100%, maybe just become 90%, 98, 95%, we will see lung sliding and A line. And if the ratio is lower to maybe 95%, you will see the B lines or even more B lines. And if the air is more less, more become maybe consolidation, even pleural effusion. So we call it pneumothorax, A line, or we call it air failing airwayler, and the B line and the consolidation, and also pleural effusion. So PABCP. So it's a different word, give us some kind of ideas. So use this kind of definition, we just combine these two images together. First is from CT scan, you see the vascular shadow is thickened and interlobular fissure is obvious. And this kind of things in a CT scan in NCP patients is very common. So in this condition, the lung ultrasound will show you this kind of a B line and the pleural little bit change, and is a focal change. And also now the pleural line is still regularly or a little bit irregularly. And in the lower part, you see here is GGO. We call it ground glass shadow, like that. You see this part is more or less same than this lung condition, the B line, or maybe from B7 to B3 lines. And if the condition changed from maybe just a small part or even in a normal condition to multiple ground glass shadow, like the left upper side, this image. And also this is in the aggressive phase in this disease. We see B7 lines, B3 lines, and also sometimes you will see during the inspiratory phase or respiratory phase, the B line change to the other, maybe from A to B or B7 to maybe B3, or even to diffuse the B lines like that. You see here. And let's move on to the next slide. If the patient's conditions goes to more severe, you see a massive exudative shadow here, and you see sometimes you see it's in the outer part, outer lateral part of the lung, and even sometimes in the lower part of the lung, in the gravity dependent part. You see this still is in the interstitial part, is not a lot of fluid inside the alveolar, so you still can see the B lines and the pleural change from maybe more irregular. You still can see here the lung sliding B lines, but the lung sliding now is seemingly is more slow or restricted or limited. And in this part, you can, from maybe small part to maybe large part or even diffuse the infiltration. I think the lung is the lung ultrasound is same. So just the area you see from maybe only maybe left side, lower part of your lung, maybe become for the whole lung. You can see the same image from your lung ultrasound. You can see this kind of lung sliding and B-lines. And if the patients become more worse or patients happen in the lung, where maybe small consolidation, you will see the very small bronchi signs or bronchogram signs inside here. And sometimes we use this kind of sign to maybe recall you or give you some ideas, think about the pulmonary embolism. But in this kind of this signs also in NCP can find this. It's a shred sign, something like this. You see here, and you see here is some local small nodular. So you will see this kind of shred sign. And massive consolidation is responding or seen as this kind of consolidation. And now is, I think most of us is very familiar with this. As tissue-like signs and airway bronchogram, and also in different regions, you see a lot of these kind of things. And if a dynamic airway bronchogram and give you the ideas, tell you maybe the airway now is okay. And if patients can cross the very difficult or very severe phase of this disease, the lung will become absorb this infiltration and then become the microfibrosis phase. You will see the focal fibrosis, extensive fibrosis, and also diffuse fibrosis. And if you see in this condition, you see your lung ultrasound, you see irregular pleural thickening and also unequal B-line spacing and variated distribution. And in this condition, you will see the lung sliding become very small and very difficult or limited. So this is this kind of things. And during this kind of, or in this kind of disease or patients, you can see in the different area of the lung or chest, you will see maybe the A or B or C conditions coexist. You will see in the upper part, you will see maybe it's A lines, lung sliding is okay. But in middle part, you will see maybe infiltration, B lines, irregular pleural lines. In the lower part, or in patient's backside, you will see maybe some part become a consolidation, or even you can see it's a pleural effusion or airway broncho, even it's static or dynamic. So I think it's different, but you can see this in same patients. Mostly in ventilated patients, you use some positive pressure to support the patient's breathing, but sometimes you will see these kind of things together. You see here is a lung ultrasound. You see in different parts, we can see in same patient. I think not only in this kind of disease, in our routine patients in our ICU, you see some septic shock patients or the ARDS patients, you always see this kind of signs from lung ultrasound. And several situations in which lung ultrasound is easily missed. You see, this kind of pathology is not always the peripheral part happened in the lung. Sometimes it's happening in the central part of the lung. And during this condition, the lung also can't reach this kind of disease or the change of the lung. So if you get the negative finding of your patients, and the patients tell you is some short of breath, fever, and also the oxygen situation is very low, you have to think about the other things. First of all, maybe pneumothorax, or the other things like maybe pulmonary embolism. But also you should think about maybe central part consolidation, or even the airway is occlude. So you have to keep in your mind, the ultrasound sometimes can give you some misleading ideas. So if we use this kind of tools, put them together, and you will see some, we call it our lung ultrasound the point of care, but compare with CT scan, is much frequent. You can use close to your patients, maybe per 6 hour, even per 2 hour. Whenever you want to, you can use the ultrasound to give the patient's examination. But the CT scan, you can't. So you just put this kind of together, we integrate it together, we can see something deeply, we can, from CT scan or the other image tools, to give us some helps. But if you use this, and based on this kind of information, you use your ultrasound more frequent and more close to your patients, and the monitor maybe is much better to help your patients. You see in the patients, you see in the normal condition, you see A lines, lung sliding. And in the infiltration part, you will see B lines, B7s, this thing like this. And also you just put this together, you see in multi-area, you see different area, you can see the B lines. And even sometimes you see, oh, sorry, this, I didn't translate this in English word, sorry. But this diffused, how to say, the ground glass shadows in the diffused lung. You can also your B lines from B7, B3, or even diffused B line. You can see in the area of the lung. You see this same, more or less same. And if the patient changes, you just I just emphasize this. In this area, you try to think about not only you use your probe just to point to one area of your patients. You have to think about the whole lung, from the maybe upper part, from the lower part, from the how to say this, maybe lateral side to back side. I think it's very useful. And also you have to think about the A line, B line, also consolidation, shred signs, and the other things. Put all these kind of things together. And also maybe you should integrate some maybe oxygen situation, maybe oxygen pressure inside the blood gas, and the other things, and also some signs, some symptoms from your patients, and the changes, and you put together. And even I think the most important and the last part is you should think about your interventions, what kind of treatment you give your patients. So you put all these things together, you will see your patients, you can integrate all this information together, you can think about this. So now we also need to integrate all this kind of information. You see, we combine CT scan and also our lung ultrasound together. From maybe the point of care, even very difficult to get this kind of information. Now you stand close to your patients, just to get maybe more frequent, and from static information to maybe a little bit dynamic. And And also these two images you can put together and always the same, can tell us the same information. So I think this is from maybe A line to maybe the consolidation or a pleural effusion. And if from the CT scan is some normal condition, but the diffusion, how to say that is, you see it's a synchroning in constancy extract movement is, I think this is still is a lung ultrasound image. But according to the patient's the phase or the condition, the lung will become maybe from a normal condition to maybe consolidation from very small part to maybe the huge area from maybe how to say the lateral lung to the both the two sides of the lung. And if you go to your lung ultrasound, you will see the A line sliding is okay, the pleural line is okay, and also the move very smoothly, and to maybe focal B lines, B7 lines, multiple B7 lines to maybe to B3 or the diffused B3 lines, or you see the whole lung. And if the condition become more worse, you will see, or sometimes happen is nodular things with the lung. You will see it's a shred sign, tissue sign, or tissue-like sign, or the hepatic like sign, something like that. And we see the consolidation. So if the patient's condition is more mild, moderate, or even no obviously fevers or the signs or symptoms, the patient's condition is okay, our lung ultrasound is nearly we can see is okay. But the patient's condition more severe, you will see the lung ultrasound image, you will find the positive findings more and more close to the disease. So you can think about this, and you can think about the lung ultrasound can help us in every patient every time. So now we finished our I think the basic part. Now we have to go into our practice part. If you use this kind of pathology information, image information, and now you have to think about the pathophysiology part. Image or the pathology is just give you some ideas about the damage, how deeply, how severe of these kind of things. But if you use this kind of information to integrate or plus the other information you gathered from your patients or from your team, you see this kind of things, what happened, what's the relationship between the pathology, the image with the disease, or how severe of the disease. So we have to think about pathophysiology. So if you think about this part, you will see in the very early stage, the virus is damaged mostly in the alveolar and in the epithelial cells. And sometimes it's damaged the pulmonary interstitial part. But in the later stage or later phase, we will see the endocellular cells, and also our vascular was damaged. You will see some embolism inside this kind of vasculars, and also sometimes you will see the hemorrhage inside the lung, and even necrosis you will see here. So if you think about these two sides of this disease or the mechanisms, you have to think about the hemodynamic and oxygen delivery, oxygen consumption. So in this area, you have to think about the movement, some damage of this kind of movement. We all very familiar with the ARDS. You see the cross alveolar pressure is, or we can say is the driving pressure is very important. So if the patient's in a very stressed condition, patients in a very deeply, very strong breathing, we will see the inside the pleural space, the pressure is very low in the maybe inspiratory phase. And in this condition, you even can see you just give very low pressure support of the patients. You can see patients maybe tidal volume more than 1,000 milliliter per time. So in this condition, we try to think about these kind of mechanisms is tell us about the driving pressure now is too high. You have to think about in this part, patients something like this in very strong exercise. So the muscles need oxygen delivery, need some maybe glucose supporting, something like that. So this means you have to patients release lots of maybe some not cytokines, epinephrine, something like this. So make some heartbeat increase, the blood pressure increase, and also the workflow for the heart, for our respiratory pump is very strong. So in this part, you see if the patient's the driving pressure is very high, you have to think about to control this part, to control the damage of the alveolar of the lung. And also in this part, if patients the blood flow is very high, that makes the pulmonary vascular network is receive a lot of fluid. And during this part, the fluid, the flow, the velocity of this kind of flow is very high. That means the pressure between the endocellular part of the vascular and also the alveolar part of the epicellular part. So the pressure also across this kind of tissue is also high. And in this part, even we have to think about some elderly patients, some have some kind of heart disease patients, the diastolic function very weakness patients, and the left atrium, the pressure is becoming high. So in this part, the patients in a very stress condition, the cardiac output, the heart working is very strong, and the cardiac output is very high. In this condition, will damage the pulmonary, and also in this part, in ARDS or in this kind of disease, I think it is something same. The pulmonary artery pressure in these patients is very high, and it damaged your right ventricle function. So in this part, the patient's hemodynamic condition is even become worse. So if in this kind of patients, you think about this kind of pathophysiology and you combine this to your clinical manifestation of your patients and also your management of your patients, you will think about this. You think about you use some maybe non-invasive ventilation to control your patient's workflow, even respiratory workflow, the heartbeat, and if the patient's in a very stress condition, even sometimes the patient's in anxiety condition, very strong, or delirium, so you use some sedation drugs to control this. You sometimes have to think about intubated your patients, let your patients under ventilation support to help your patients and to control your patients. Even sometimes you have to control your patients' temperature, body temperature, to make your patients the balance between oxygen delivery and oxygen consumption. So if we can think about this, we can summarize this part. We move to our patients. So you think about your lung damage not only from the virus, from even sometimes from our respiratory movement, our driving pressure, sometimes also from the vascular part, from our workflow, blood flow. So the patients in very high blood flow condition, we have to think about you should control that. But sometimes you use the fluid resuscitation, or you just use diuretic treatment. You will change your patient's preload, afterload, cardiac function. So at that time, you have to monitor your patient's hemodynamic condition. And nowadays, more and more elderly patients stay with us. And especially in this disease, the more older the patients, more easy, more risk to the severe condition. So that means the heart coexist disease is more frequent. So you think about this, you have to think about the ultrasound. You have to monitor, or even you take gland to see your patient's heart function. So you will see this different maybe subcostal part, maybe is the other part you can use. You can use IVC, or you use parasternal, or the other part to see your patient's heart condition. So we can integrate all these kind of tools together, and the basis mechanisms together. Let's say a patient. This patient is a male, 62 years old, hospitalization on February 5th, 2020, due to a fever and a cough. Outpatient imaging suggested multiple ground glass opacity in both lungs. And the various RNA is positive, diagnosed as viral pneumonia. And some kind of how to say this, stereos. We use this one is very difficult to pronounce. So it's kind of these drugs, 40 microgram per day in 7 days, and use some kind of protein 5 days microgram per day, and also give some antibiotics and other kind of treatment, and also use some yes, this is kind of antibiotics, but the symptoms did not release. And the patients have shortness of breath, respiratory rate is 40 beats per minute, and oxygen situation is 95%, and 100% high flow oxygen inhalation in February 16. So the patient was transferred into ICU. In admitted to ICU, the patients admittedly intubated due to this very severe respiratory failure. And simultaneous, the central venous catheter was cannulated. And after that, the patient's vital signs, heartbeat 140, blood pressure is more or less okay, but SpO2 is 90%. The ventilator, the setting is FiO2 is 100%, PEEP 16, and pressure support is I think it's a pressure control mode is 14, and respiratory rate is 20. And they did the gas examination, is pH is 7.12, and PCO2 is 7, and PO2 is 93 millimeter mercury, and the lactate is 1.5. So the patients still have the very strong respiratory stress. So the doctors decide to give patients some kind of fentanyl, propofol, and the other things, drugs to control the patient's condition, and even use some drugs to relax the muscles. And this is the ventilator siting. They changed this ventilator mode from PEC to volume control. The tidal volume is 380, and frequency is 30 and PEEP 14, and plateau pressure is 35, and the driving pressure is 21, and static compliance is 70, and the patient's tidal volume minute volume is 11.5 liter per minute. And after this, the gas examination showed the PCO2 is 78, and the PO2, the oxygen index now is I think it's lower to 83.2. So the patient's condition become more severe. And the X-ray showed this diffused opacity. We call it the GGO. And the CT scan, I think something is more or less same. In this time, patients still not very strong gravity-dependent condition happened with the patients. So they also did the ultrasound examination. They use Professor Xiaoting published paper is modified CCUE protocol. They gathered some information from the patients. You see the IVC. I think the patients now still have a spontaneous breathing, and the patients the IVC changed a lot. And also the subcostal view 4-chamber heart, you see the right ventricle is a little bit bigger, and you see the peritoneal parts, the left ventricle is still okay, but we see the cavity, the wall of the left ventricle a little bit thickened. And it's not very clear, but we can see some little bit end systolic part phase. We can see it's more or less we can see it's the D shape. And from the apical part, the 4-chamber view, you see the right ventricle is enlarged, and the right atrium is more or less okay. And you see the subcostal part, you see here is the left ventricle from, I think, the apical part of the heart. You see it's a D shape. So the patient's the heart ultrasound give us some impression is maybe it's the PAC or the left ventricle, the pressure or pulmonary artery pressure is high, and the patients still have very strong respiratory driving, and patient in maybe stress condition, and during this time we have to think about our maybe it's because of very high ventilator siting of this and very severe pulmonary condition. And let's see the lung ultrasound. They also use the modified CCUE examination. You see the 8 area examination. You see confused B lines. The lung sliding is a little bit limited, and in the lateral part, you see pleural effusion, and under the pleural line, you see a little bit of consolidation in this area. But until now, you see the patient's lung is diffused B lines, because of the CT scan showed us of that condition, they didn't do the back part of the ultrasound of the lung. So after this, the doctors also measured some data from the cardiac ultrasound. You see IVC is 1.95 and the VTI is 20. So that means the patients, you see the heartbeat is still in high condition. So that means the patient's cardiac output is very high. And also in this part, here, we see the patient's the cross tricuspid valve pressure is 51 millimeter hydrargyrum. That means the patient's pulmonary artery pressure is more than 60 millimeter hydrargyrum. That is a very high pressure. So that I think this kind of information we put together, the patient have the right heart function now is compromised. So we try to give some kind of interventions. So the doctor gives the decision is use the prone position 6 hours per day and turn over rapidly. This patient's CT scan showed us the patient's now is still in a diffused infiltration phase. Is not I would say is gravity dependent part is a lot of consolidation. So they more likely to use the turnover rapidly, more frequent to change the patient's position, and use a more deeper sedation and control patient's body temperature, and they use some dehydration drugs to give the negative balance, and 3 days accumulate water is 2,000 to 1,500. And not only this, and also the other interventions from a circulation part, you see the central venous pressures, they keep it into 13 to 11, and non-epinephrine to 0.5 microgram per minute per kilometer, and keep the blood pressure in normal range and patients lactate in normal range. And you see the respiratory condition here before the prone position as PCO2 is 80, PaO2 is 65. And after this, the patient's condition little bit better than before. And also you see the plateau pressure is lower from 36 to 34. And the tidal volume is controlled to 360. And after this, the static compliance from 17 to 19. And I think the day after of this, the patient's conditions was changed. The body temperature become 39.5, and amount of sputum increased significantly and showing yellow sticky. And the circulation now is support is CVP 40 epinephrine from 0.05 to 0.6 microgram per kilometer per minute. And the ventilator condition is from now I think you see all of this, but the patient's FiO2 from 60% to 100%, and the ACO2 is increased to 105, and the pH is 7.19, and no urine, and patients have now acidosis, and so they decide to give patients CRRT. At that time, they also did the CCUE examination. You see now the IVC is enlarged and fixed, And you see the short axis is in a very round shape, and the heartbeat is still fastly, and the left ventricle, the systolic function is still okay. And the right ventricle is enlarged. So we see all these things, and also you still can see this in some part sometimes in the circulation, the in the heartbeat phase you see the D shape, and so they also did the lung examination. You see some part become a consolidation. The airway broncho inside that you see the very bright points here. That is a bilateral diaphragmatic points. See that these kind of things. So during this part, these things you see the patients now is just happened is, I think, hospital acquired pneumonia. Maybe we can call it ventilator acquired pneumonia. So they have to think about change the strategy of the treatment to the patients. And sorry. Oh. Here. So the treatment, they changed from that condition to the pro position for 16 hours per day, and use the adequate sputum drainage method, and improves gravity dependent site. They use bronchoscopy to drainage the sputum. And also the ventilator conditioning, they changed from the volume control to supporting still volume control. The PEEP to 10 and tidal volume 390, and the plateau pressure lower to 30, and FL2 is 90. Hemodynamic adjustment, they use CVVH to drainage lots of fluid from patients. So they drainage negative, the balance negative 6,201 milliliter. And the IVC is become narrowed than before. Now it's 1.4 to 1.5. And they still maintained the blood pressure, the perfusion pressure is, or because the mean blood pressure is 80. So the ACP, the acute commoner now is relieved, and CO was maintained, and the reasonable level. That means lactate is okay. And the autonomic urine volume recovered to 50 to 100 milliliter per hour. So during the prone position, they did this kind of a lung examination. You see the lower part, the backside. During this condition, you just can check the backside and also the lateral of the chest. You see most of the part is consolidation. And after this prone position, the patient's condition is getting better, changed more better than before. And so I think my time is more limited, so I just speed up. So the heart condition now is, you see, is more better. You see here. You see the heartbeat is more or less okay, and the IVC is 1.93, and the heartbeat and the right side and left side ratio is become more reasonable. So the patient's condition is getting better. I think now you think about your critical ultrasound. If you follow your pathology, image, pathophysiology, and you follow your clinical information, and give the right decision, I think you can treat your patients, help your patients. So after that, we all know this, our ultrasound machine from very huge volume now it's become more small and more easy to carry or pocket. So you see this kind of things. So if you put all this kind of information together, now you can see it's published in this JAMA cardiology. Now it's time to add the fifth pillar to the bedside physical examination. Now, before of this, we only have 4 kind of the pillars, but now we have the ultrasound to help us, especially in this NCP or the COVID-19, the decision. In this condition, you very difficult to gather. You use a stethoscope. You use because of you usually you wear maybe three pair of gloves. So makes things your feeling, your action is very difficult. So the ultrasound now is much better, much useful tool to help us. And also, if you integrate this kind of things together, you can give you integrate this kind of tool into a telemedicine, tele-ICU. You see here, sorry, this is, I didn't translate in English. It's Wuhan Zhongnan Hospital, the critical care department. This guy is the director of this department. And in this, how to say, the condition, their hospital saved a lot of lives, and the survival rate of the very severe patients, the more lives is I think is the best in the whole city. And this is his colleagues, and this maybe in the Sunday night, Dr. Professor Iman Hong will give all of our colleagues the speech. And this is me as Dr. Xiaoting and Dr. Zhu Ran. We stay together to use this kind of tele-ICU information and integrate the lung ultrasound. You see these patients in a very severe condition. They use ECMO, the VV mode ECMO, and the patients still in a very lower central venous oxygen situations, artery oxygen situation, the blood pressure in this condition. And during this discussion, the experts talk to each other, discuss a lot of the information with the patients. You see the patient's condition was a little bit changed, and we discussed a lot about some circulation part of the heart condition and the pulmonary conditions, the antibiotics, and the other strategies of the treatment of the patients. And also you can see the IV in the IVC, the drainage tube of the ECMO, and we change the position of this to lower the recirculation, the drainage, the increased drainage volume. And after this, you see the patient's condition is much, much, much better than before. The oxygen situation is better and the blood pressure is better. You see, you use these kind of tools not only just beside your patients, you close your patients, and also these kind of things, what you say is you can transmit to the experts, ask them maybe second opinion or third opinion to help your patients. So I think now I should conclude this topic. I think the NCP image shows interstitial change distributed in the outer zone, showing gravity-dependent changes. And great shadow is typical and the basic feature. And vascular synchrony is common phenomenon. And the image changes with condition variation. And the lung ultrasound is a help tool in NCP. And the significance of the pulmonary ultrasound is suggesting primary disease and pathological injury which can get treatment and suggest prognosis. And dynamic assessment are more close to or more frequent to check your patients again is the key point. Okay, thanks.